We identified signs and symptoms of cystitis and pyelonephritis. We analyzed the results of a urinalysis. We ensured urine cultures are taken in patients with pyelonephritis and recurrent cystitis, and we looked at the common uropathogens. Now, the next learning objective is, given a patient case, recommend effective drug therapy for treatment of cystitis or pyelonephritis. Now let's take a look at treatment of cystitis. Here are the recommendations from the 2010 IDSA guidelines. Fluoroquinolones such as ciprofloxacin and levofloxacin should not be used as first-line agents for empiric treatment of cystitis, given their high propensity for collateral damage and the benign nature of cystitis. So although fluoroquinolones are extremely effective in treating cystitis, but they have a lot of adverse effects, including collateral damage, meaning that they will disrupt the microbiome, select for resistance, as well as leading to Clostridioides difficile infection. Now, oral beta-lactams have lower efficacy in general and should not be used as first-line agents, especially amoxicillin and ampicillin, due to poor efficacy. And this is likely because of poor bioavailability of oral beta-lactams in general. Now, if somebody doesn't have any other options and we must use oral beta-lactams, it is best to use amoxicillin clavulanate, cefaclor, which is a second-generation cephalosporin, cefdinir, which is a third-generation cephalosporin, or cefpodoxime, which is also a third-generation cephalosporin. However, in general, it is best to avoid oral beta-lactams because of lower efficacy. Now, the IDSA guidelines actually recommend trimsulfa or trimethoprim sulfamethoxazole as a first-line option, but this should be avoided for empiric treatment of cystitis because local E. coli resistance rate is more than 20% across the United States. And 20% is the threshold that IDSA recommends for resistance in order for it to be significant enough to avoid trimsulfa. So it should be avoided because in the United States, everywhere the resistance rate is more than 20%. So essentially, we have 3 first-line drugs for cystitis available in the United States. So we have nitrofurantoin, we have fosfomycin, and pivmesolinam. Nitrofurantoin should be used for 5 days. And this is BID dosing, so this is specifically the macrobead formulation. The adverse effects in general includes GI disturbances, so nausea and vomiting. Some patients may experience headache. One of the rare adverse effects of nitrofurantoin could be pulmonary fibrosis, and typically when this does happen, it happens when people take this long term. So if people are taking it for several months as opposed to 5 days. So with 5 days of use, it's really extremely rare. Now, remember that the package insert says this is contraindicated in creatinine class less than 60, but per Beer's criteria, it's okay to use in creatinine class 30 to 60. Fosfomycin is a single dose, so 3 gram one dose is the current recommendation. Whether more doses are required, we need more studies to find out. In general, the adverse effects of fosfomycin, diarrhea, nausea, headache, in general well tolerated. This is a powder that comes in a sachet, so this needs to be mixed in water and consumed. It's relatively more expensive, so it's somewhere between $30 to $40, but then again, it's just the 1 dose. And more recently, in 2024, pivmesolinam was approved in the US, although this has been on the market outside of the US since the late 1970s. Pivmesolinam, IDSA guidelines recommend 400 milligram twice a day for 3 days. Now, note that this is different than what the package insert is approved for. So this is the package insert is for 200 milligram 3 times a day for 3 to 7 days. Now we know that TID is not does not improve adherence, so BID is easier to adhere. So the guidelines do recommend higher doses, but less frequently to improve adherence. and the duration is for 3 days. So there is a network meta-analysis that was published in Lancet Infectious Diseases that showed that 3 days is just as good as 5 days or 7 days. So there's really no need to go beyond 3 days if we're doing the high dose. In general, pivmesolamine is very well tolerated. Now, these three agents are considered first line because they have narrow spectrum of activity, and they primarily concentrate in the urine, so they are unlikely to go to other sites in the body, so their propensity to cause collateral damage is very low, and resistance to these agents remain pretty low in E. coli. Now, when it comes to treatment of pyelonephritis, again, the same issue with trimsulfa because the rate of resistance is more than 20% across the US. And empirically, it should not be used. However, in pyelonephritis, there will always be a urine culture. So if the urine culture results come back and it's susceptible to trimsulfa, only then it is okay to use trimsulfa. But empirically, before the urine culture results are back, it should not be used if other options are available. Now, IDSA guidelines also recommend fluoroquinolones as first line for empiric treatment of pyelonephritis, but they do say that they should be avoided empirically because local E. coli resistance rate is more than 10%. So 10% is the threshold for fluoroquinolones, and across the United States, resistance rate is more than 10%. So they should not be used empirically, but once the results of the culture come back, if they are susceptible to fluoroquinolones, only then it would be okay. But then again, fluoroquinolones, we have the issues of collateral damage and adverse effects, so they should only be used if other options are not available. Now, regardless of the empiric agent chosen, therapy must be directly based on the results of a urine culture. So it's extremely important because pyelonephritis is relatively more severe infection, and it can lead to bacteremia, which can become a pretty severe infection. So here are the first line drugs for pyelonephritis per 2010 IDSA guidelines. So essentially, for the most part, ceftriaxone is what's commonly used. It is very affordable and it's easy to use. It's once a day dosing, so 1 gram once a day or every 24 hours. Now, duration of treatment for pyelonephritis is 7 days. In general, ceftriaxone is well tolerated. However, it is a third generation cephalosporin, so it's relatively more broad. So when the urine cultures do come back, it's best to de-escalate to the narrowest antibiotic that's susceptible. And cefotaxime is also a third generation cephalosporin, so it's going to be pretty effective, but it's dosed every 8 hours, so this one is rarely used. And of course, if somebody has cephalosporin allergy, we can use aminoglycosides, so either gentamicin or tobramycin. However, keep in mind that aminoglycosides are extremely toxic, so nephrotoxicity, ototoxicity, and rarely neuromuscular blockade can also occur with aminoglycosides. So in general, they should be avoided if there are other options. If you cannot avoid other options, only then it is okay to use aminoglycosides simply because of toxicity. Otherwise, they are pretty effective in treating all types of UTI. Now, let's take a look at the resistant patterns in urinary E. coli isolates across the United States. So this was a study that compared the resistance rate for three drugs, so nitrofurantoin, trimsulfa, and ciprofloxacin. And they compared the rates from 2003 to 2012. And this study was published in 2016, so it does take a few years to collect these data and publish it. They also compared two groups, so the age group 18 to 64 years of age and age 65 and older. And what we see is that when you compare 2003 data to 2012, there's not significant increase in resistance to nitrofurantoin. So that's why nitrofurantoin has pretty much remained pretty effective against E. coli. So that is recommended first line for cystitis only. And for trimsulfa, you can see that since 2012, actually resistance rate for both age groups has been more than 20%, and 20% was the threshold for resistance in order for it to not be used empirically. So you can only use it once urine culture results are back and show that it's susceptible to trimsulfa. Now, when you look at ciprofloxacin, you can see that since 2012, the resistance rate has been more than 10% for both age groups. So the threshold for ciprofloxacin is 10%. And so for that reason, both ciprofloxacin and trimsulfa should not be used empirically for pyelonephritis or cystitis for that matter.